That's Kaan.
Hello. Hello,
Hey,
Marcel.
Kaan.
Hello, Alper.
Hello Kaan. Sayın hocalarım, kıymetli meslektaşlarım, kıymetli katılımcılar, üzüntümüzün çok büyük olduğu günlerdeyiz. Hayatı kaybedenlere rahmet diliyoruz. Yaralılara acil şifa diliyoruz. Dualarımız, kalbimiz bu felakette canı yanan herkesle. Bugün Profesör Doktor Marcel Nurcem hocamız bizimle beraber. Dear Professor, welcome. I want to invite Kaan as well, and he and his team from Ankara University are involved in the ongoing relief efforts in the region. Evet, Kaan hocam buyurun. Siz ne durumdasınız oralarda?
First of all, let me start by thanking Marcel. Actually, I'm not going to tell like Professor Nurcem, but rather than I would like to introduce as Marcel, because he's very close friend of ours, not just only for Dr. Alper and myself, and for the Turkish community as well. I should also emphasize like Dr. Hüsnü as well, because Dr. Hüsnü made his specialty studies with Marcel in San Antonio, Texas. So previous coming to this meeting, I had a meeting with Lisa Koenig and Hüsnü. So they are sending best regards to you, Marcel. Just half an hour later, we were discussing about Lisa's new updated version of her book. So she would like to send her best wishes to you. So I'm just telling that.
Okay, thank you.
And secondly, I would also like to mention, as Dr. Alper already mentioned, that we are in Adıyaman city of Turkey, which affected from the earthquake, which is close to actually more or less close to the southeast part of Turkey, and close to like Gaziantep, Kahramanmaraş, and also Mardin in that region as well. There were like really massive earthquakes, and to say the truth, there is a huge demolition in the area. So here, as Ankara University, we are trying to relieve the people, and also we are trying to make a treatment for the oral diseases, especially like emergency. I would like to switch to Turkish a little bit, and then I'm going to give the word to Alper for the initiation of the webinar. But again, thank you very much for being with us and for accepting to give a webinar. And I will be very delighted to hear the lecture, because it's gonna be like, so to say, change our minds in another way around here. So I can also would like to enjoy the lecture as well. Thank you very much. Sayın hocalarım, ilk başta bütün katılımcılara hoş geldiniz demek istiyorum. Deprem sebebiyle ara verdiğimiz, deprem felaketi sebebiyle ara verdiğimiz webinarlarımızı bu dönem Amerikan Maksilofasyal Radyoloji Derneği Başkanı olan Doktor Marcel'le devam ediyoruz. Girişte dediğim gibi Marcel bizim için sadece Alper ve benim için yakın bir arkadaş değil. Aynı zamanda da birçok Türk, özellikle de adını da belirtmek lazım, Alper'in daha önce çalıştığı Hüsniye'nin uzmanlık hocası ve de bizi yakından tanıyor. Bu sebepten dolayı da ona çok teşekkür ettim. Sağda biraz önce bahsettiğim gibi gerçekten her ne kadar deprem felaketi henüz atlatılmamış olsa dahi sahada özellikle acil sağlığı açısından çok büyük bir efor ve de aslında da ihtiyaç mevcut. Tabii bununla ilintili olarak siz sayın üyelerimizle bilgilendirmek adına ben sahada olduğum için Sevgi Hocam katıldı. TDB'nin bununla ilintili bir organizasyonu olacak. Biz de hem eğitim hem de TDB'nin bu organizasyonuna katkı vermeye çalışacağız ve katkı verme dileğindeyiz. İnşallah bu günler hızlıca geçecek ve normal hayatımıza ve de faaliyetlerimize geri döneceğimizi düşünüyorum. Yeniden çok teşekkür ediyorum. Sözü Alper arkadaşıma bırakmak istiyorum.
Çok teşekkürler Kaan Hocam. Artık yine İngilizce yayına ufak ufak geçiyoruz. Dear colleagues, welcome to our webinar series. It's an honor for me to host Professor Nujem, who is going to give us a lecture about interpretation, image interpretation. To begin with, let me introduce you Dr. Nujem with his CV as well. Dr. Marcel Nujem is a professor in oral and maxillofacial radiology. He is an alumni of the University of Texas Health Science Center at San Antonio, where he completed his Master of Science degree in Dental Diagnostic Sciences in 2006. His teaching career in dental radiology spreads over 30 years, where he fulfilled his various roles and positions that culminated in heading and directing oral and maxillofacial radiology graduate program at University of Texas Health Science Center at San Antonio between 2008 and 2019. He is also a diplomat of the American Board of Oral and Maxillofacial Radiology. He is the president of the board for the year 2023. He led various seminars at national and international meetings and has authored numerous articles and abstracts, and he is the recipient of multiple international awards. In 2007, Dr. Nujem started a radiology reading service in the dental school in San Antonio, service used by hundreds of American and international doctors. And I had a chance to be one of his students because I enjoy his brilliant lectures every time. And I feel that we are so lucky to have one right now. Right, Dr. Nujem?
Yeah, no,
Welcome.
thank you. No, thank you so much. Okay, now I'm gonna need the permission to share my screen with you guys. So I'm gonna do this and you will let me know if you can see it.
Yes, we can see it.
Okay. Yeah, why is this thing in the middle? Let me see. Okay, it's up now. So can you see the screen? Everything's okay? Okay, good. Okay, so thank you again, Khan, Alper, for this opportunity. I know that, I mean, I wish we could do it in a more joyful times. We enjoy it more, but I know how heavy your heart is. You know, I'm from a country that was shattered by war for 30 years and still going on, and I know what does it mean to see your beautiful country being destroyed. We lived the explosion of Beirut recently, and you all know about that. And I really don't know what to say. It's beside that, keep praying that God will always be with us. You know, God has a plan for all of us, and we all believe that, you know, good will prevail at the end. Yes, we lost a lot of close people. I know that all of you lost friends and family, and you know, it's 50,000 people till now. That's disaster.
Yeah.
But I know what kind of people the Turkish people is, and I know like you're very close to us, and you know the phoenix bird. You know what the story, the legend of the phoenix bird. You know, the one that dies and then comes back from ashes. I know that you and us will be able to come back from ashes and rebuild the beautiful place that you live in.
Yes.
I'm gonna get emotional now. I need to stop seriously because that's That's too much. I also want to thank one person, Hasniye Demirturk Koja Sarach is her last name now. Hasniye is the one who introduced me in a way to Turkey. Yes, I spent my honeymoon in Istanbul, and then I met her in Norway in 2013, and she invited me once, and we spent amazing time, and because of her, I met Alper, I met Khan, and I met many brilliant Turkish radiologists. I would never be able to thank her enough. And then she came and spent 3 years with me in the program. She graduated from our program, and oh my God, she gave me the hardest time ever. No, I'm just joking. No, she was one of the best. Anyhow, okay, so let's start now. Now, this presentation is going to be a little bit different. It's not classic. It's not like you always do. I'm going to ask everyone to have your cell phone with you, not to take pictures for me. I know you can take my picture, of course, but please keep your cell phone with you, because now we're going to work on our cell phone. So I will let you know how this is going to happen. Okay, so did the slide move? So we're okay?
Excuse me?
Did you see the second slide?
Yes.
Okay. So from my country to yours, our deepest condolences. We are very sad for what happened, and we lost many citizens from our country in the earthquake. So now I'm gonna ask you to do that. I'm gonna ask you to log in on your cell phone to this website. Hey, move. No, wait. No, this needs to disappear.
The writing on the top of the slide here with polev.com, that one? To log in?
Yeah, I need to how can we bring this? Okay, yes, it's here. Okay, so as you see, pol.ev, and I sent it on the group also. So if you click on your phone, if you log into polev.com/Marcel Nujaim night 20, you're going to be able to see something like this. I will do it in front of you. And I see some people who are starting to answer. Okay, so please, if you want to answer wrong, I would love to do that, just to make sure that I will answer wrong. Okay. Just to make sure that things are working, and then we start. Okay, so you're supposed to see something like this. I don't know if you see it. I don't know who put Liberia, but I'm okay with that. Okay, you see? No, definitely not Liechtenstein, but please don't say Libya. Okay, so I'm gonna put Libya, and it's gonna work. Okay, you see how it shows. So this is what we're gonna do now. Okay, now, perfect. Let's continue. Now, the content of this lecture is from my own office. As you see, this is my office. I don't see patients. All what I see is cases from all over the world. Okay, I receive those cases, I do reports for them, and I send them out. Unfortunately or fortunately, in many of those cases, I do not receive any clinical information, or very limited clinical information. And I know that all radiologists are the same. So Khan and Alper and Hasdi, everyone, right, yes? So they send us the images and we have to guess. So unfortunately, that's the nature of the beast. We have to deal with it. The most important for us is to look at the images, try to make as much as we can from these images. you know, every single detail is very important. And we need to go into those small details and try to extract from them, beside what's happening clinically, we try to extract from them the maximum information that can give us an idea about what's happening. As I always say, we talk to the bone. The bone is the person who is telling us what's happening to him. You know, if you see this effect, so you know that the lesion is doing that, so this is a kind of lesion. You know, like you have your kids are playing, and then one of them will say, okay, my brother did that. If you have 3 or 4 kids, if you know, if you hit him on the head, you know that it's gonna be bigger than him. So you know who the big guy who hit him. Whatever. Okay, so this is an example of how we can deal with that. So what we're gonna do now, I'm gonna go case per case. I will open the case live in front of you. We will discuss it, and then we're gonna have some questions and some answers about them. Okay, so case number 1. This is what I receive. Can you see the software now?
Yes, boss.
You see it? Okay, very good. So this is the panoramic reconstruction. I can show you the multiple, the MPR if you want, but it's not going to be very helpful. So this is the case. Okay. So this is a panoramic reconstruction, and you can see the changes. I'm going to make this a little bit smaller so we can see all the cross sections. Okay, so those are some cross sections of the mandible. Okay, you can see the osseous changes. You can see what, you know, the big expansion. You can see all the irregular outline. You can see the teeth, etc.
It's such an expansion that it doesn't even fit in the cross-section window. It really is an expansion.
And we can see here also, you can see practically there's no sinuses.
Mm-hmm.
Okay, so practically we don't see any sinuses. Okay, look how large the ramus is. Look at the type of bone that we are dealing with. Okay, good. So
first question.
Yeah, this is wrong. First question. I've deleted those. You can answer back. Okay, in which category do you place this condition? Tumoral, cystic, congenital, hereditary, or inflammatory? Okay, we're gonna give you a few seconds and then we'll go from there. Now, I know that there are 100%, but the problem is I don't know how many people voted yet. So anyhow.
So we wait for a while then.
Yeah. I know that there's a way to do that, but I didn't work with this software for a while. So anyhow, okay. So
here comes some tomorrow.
Yeah. Okay, so the condition is causing severe expansion of the mandible. It's causing a lot of osseous changes. You see the nature of the changes are different also, and plus, you know, some other findings. Okay, so it's either tumoral or congenital. Okay, let's continue. So this is a 53-year-old female. Okay, and according to the doctor, she's having a drainage in the area of 30. 30 for us is 46. So this is all what he told me, right? He didn't say anything about the condition. Okay. So when we looked at the images, when you look at the images, what is the main changes that you can describe? You know, and I'm talking about the cross sections. I'm going to show you the cross sections again. You know, when this is covering the whole thing, is this a benign tumoral? Is it caused cystic expansion? Is the bone inside reactive / sclerotic, or this is a low-grade malignant? And look at that. Okay, look at those changes here. Look at these areas of this. This is not a normal bone marrow. This is something that came up later. Look at this. Okay, so this is the root, and look at these changes. Okay, and then you have suddenly nothing, and then you have these high densities, and then we keep going, and then okay, oops, look at those. Look at this mass of bone with a big expanded mandible with a white, low density, very low density area. Okay, so those are changes. I mean, you can call this a disease of the bone. You see, it's the bone that is changing its nature. It's not a cystic lesion. You know, we all know how cystic lesion behave. You know, that's epithelium and growing, etc. We're not going to go there. This is not a typical tumoral change, because tumoral is, you know, tumor is something that grows inside the bone. Here you see that the bone is changing its nature. So that's why we tend more to call this as reactive sclerotic bone changes, because those are inside things that are happening inside the bone. Okay, so we saw that there's something congenital, hereditary. We saw that we have a lot of bone expansion. We saw that we have sclerosis and these changes. You know, you see expansion of the bone, but you don't see perforation of the bone. Okay, we see all of those. So based on that, how do you expect the teeth to be? Normal, chalky white like chalk, you know, the one that we used to write on the board. Normal with pink spots, usually pink spots, we see them in cases of internal resorption, etc. So yeah, I'm seeing some things changes. Okay, so this is a congenital condition, and you know, many congenital conditions, they have effect on teeth. Okay, while during the development of the teeth, or because of the bone surrounding the teeth. Okay, so I know it's not going to be normal. So I'm going to give you a few seconds to change. Okay, this is how the teeth are. Okay, so they are kind of brown. You see the enamel is thin but dense, and you can see how shiny it is. And this is the area where the patient was, where the doctor was talking about the drainage. Okay, so, you know, yeah, it is what it is. Okay, and this is the patient. Okay, so the patient is 57, as they said, female, short stature. You see the tube, the oxygen tube. Okay, you see the shape of the face. Now, note that the patient is really sharp. She's really smart. She knows, she reads books. She's very aware. She's, you know, she's very cooperant. You know, like here, she's normal. Normal, okay. She talks, you know, everything, but unfortunately, she has this condition. Okay, so based on all these findings, what do you think what is your diagnosis? So here you can type stuff. Okay, on your phone now you can type stuff. Let me see if I can do that. Okay. Okay, so now I'm gonna enter my response. You see, this is my disease. It's Marcelloma. So it's benign. It's not marcellosarcoma. See? Okay, I'm seeing the results coming in. Yes, I'm seeing some right results, some right answers.
I think we need more answers.
Oh yeah. Yeah, remember guys, cherubism usually is seen in young patients, okay? And then it stops at some age. We're gonna talk about it later. Okay, so usually in this age, I don't know if this is gonna be the presentation, but remember, the body of the patient, the whole thing is changed. You know, cherubism, everything is normal except the maxilla and mandible. Yep. Okay. Okay, yeah, I'm seeing osteogenesis imperfecta. I'm seeing osteogenesis in a different way to write it, which is, I don't know what MF is, FD, OI. I don't know what are those, but anyhow. Okay,
Fibrous
so
dysplasia,
yes,
they're trying to say, I
yes,
guess.
the patient was an osteogenesis imperfecta type 3. Okay, why type 3? Because it seems that it has 10 types. So I went online and I looked for those and I did the research on it. And you know, it's a condition that has multiple types. Our patient here has type 3. And remember, between the things that we saw, respiratory problems possible. You remember the oxygen tube that the patient had?
Yeah, yes.
Because she had respiratory problems. Okay, plus bone fracture easily, etc. Triangular face. Remember how she had her big jaws, round like this? Okay, loose joints. Did you remember her feet? I can show you. I can go back. Look, you see how the feet are opening? This to tell you how loose the joints were. Okay, because it's not easy to turn your foot like this, plus the triangular shape. So you have all the features of osteogenesis imperfecta. Now, she had, and then when she had bone pulp necrosis on 46, so yeah, it was treated. So it's not the big problem. Okay, good.
And she had, I think, dentinogenesis as well, imperfecta.
Yes.
Yeah.
You know, usually it comes with odontogenesis,
and
dentinogenesis imperfecta,
yeah.
which is they usually come together. Okay, so we're okay. We're
Yes,
okay with the game. So
Yeah.
can we move to the second case now? Okay. So let's see now. And this is gonna surprise you. So look at that. Okay, and this is what I received from the office. I'm not going to give you the age now, but they could not take a panoramic because they could not fit the patient in the panoramic machine. Okay, now get ready.
Okay. I think the head is bigger than the focal trough for the panoramic machine.
Yeah, I mean, it's the whole thing is a mess. Okay,
Yeah.
so now you can see what we're talking about. Okay, the problem is I can show you stuff, but I don't know if this is a maxilla or the mandible. Seriously, no, it's a mandible. I'm joking, but just to show you, look what's happening with the bone now. Okay, this is a tooth, just to let you know.
Are there any bone? Some bone.
Practically no. You
No.
see? Okay, so, okay, good. So, in which category you're going to place this condition? Yeah, this was fast. Okay, I don't know why someone would put tumoral, but okay.
Present.
Okay, so this is definitely not inflammatory. This is definitely not cystic. Well, I can debate the tumoral. I'm not gonna say it's right. No, it's wrong. You cannot call it tumoral. But some people usually correlate that to another condition, another tumoral condition. So histologically, they are identical. Okay, I'm gonna ask a question now. So that's why some people can call it as tumoral lesion. Now, based on that, we go. The patient is 12. Okay, so she's really young, and this was her condition. So, knowing the age, knowing the presentation, knowing all what you know, would you biopsy the lesion? Yes, for peace of mind, you know, just to have, or only if you want to make a publication out of it. You never know that. Okay, definitely yes, because you want to know what is it. If the parents agree, remember, she's 12. At 18 here in the US, that's it. You cannot decide anything if you're the parent, okay? But below 18, the parents have the say. So if the patients say yes, if the parents say yes, would you biopsy the lesion? Okay, or you would definitely don't biopsy the lesion. Okay. Personally, I would never biopsy the lesion, even if the parents say that. Even if the parents insist, you know, I will tell them, okay, you can biopsy it, but the problem is what's going to happen to the healing. We don't know how the soft tissue is going to heal. Why do you want to put the kid into that? The kid is already suffering. Why do you want to put her in more suffering? So I would say no. And if they insist, I would invite them to dinner on a glass of wine and tell them, okay, guys, we don't want to do that. So probably they will accept not to do it. So definitely you don't biopsy the lesion. Okay. Okay. So now what is your diagnosis? And I know that I'm going to have only one word now, or maybe two, because some people write it in a different way. I'm sorry.
Only one answer.
Yeah, I don't know what is LHH. Langerhans, no.
Maybe, yeah.
Yeah.
It's LCH. More used for that.
Yeah, and it's gonna get bigger and bigger because we know. Now, I saw many cherubism cases in my life. Personally, this was the biggest one and the most severe one and the most dramatic one. Practically, the patient did not have any mandibular teeth, and the maxillary teeth are a mess. Okay, so we don't know what's going to happen, but we know that you know, the condition usually needs long-term treatment. Usually, you need to have a team between speech therapist, orthodontist, surgeon, ENT, you know, every kind of doctor specialty, you're gonna have it.
Unfortunately,
to deal with this. Remember that this condition usually stops growing around 12, 13 maybe, and they say it starts regressing around 18, 19. But in this case, what is regressing gonna mean? We don't know. I know that the patient is a patient in a dental school that they send me all their cases, so I can always follow up on her and see what's happening with her situation. Okay, so let's go to third case. Okay, so 57-year-old male. The patient, the doctor says, please note lucency in the mandible. And this is how it is. So he did not say lucency in the mandible. He said lucency mandible. Okay, I copied and pasted what he sent me. Is this a periapical cemental dysplasia? So This was the question. Okay, I'm gonna show you the case now. Okay, so this is the case. This is what we are dealing with. Okay, look at the bone in the mandible. Look at the external resorption of 46. Okay, note please the component of the tooth. Note the surrounding structures of the tooth, if they exist or they don't exist, because we're gonna have we're gonna ask questions about those. Look at the bone marrow.
Or try to find the marrow there.
Yeah, try to find some bone marrow and then look at it. And then, of course, the external resorption. Okay? Now, if we go to the maxilla, the situation maybe is a little bit better, but not much. You see, the teeth are, you know, we can use the word floating, so there's no bone support. Even there are some implants. Okay, remember the patient is 57. So this is something that probably happened later, because if this is happening, I don't see a doctor who has a little bit of conscience will go and place implant in this case. Okay, now, this is all what I got from the doctor. So do you think there is a periapical cemental dysplasia? This was fast. This was fast. Yes, yes, you would be surprised by the knowledge or the not knowledge of some of our colleagues. You know, this it is
Unfortunately, yeah.
I'm not gonna go deeper than that.
Yeah.
Okay, so definitely we did not have any periapical cemental dysplasia. Okay, good. Let's continue. Let's not waste time. So this is the case. Look at the bone. You can see look at the resorption here. Okay, now, in which category would you classify this condition? So what would you call it? Do you call it inflammatory? Do you call it, and it's open so you can put your stuff. Do you call it systemic? Do you call it inflammatory? Do you call it tumoral? Do you call it malignant? What is the first thing that comes to your mind whenever you see this huge, I'm gonna say, polyostotic spread condition? Systemic, definitely. Lymphoma, Langerhans congenital, malignant disease. Langerhans cell disease, I think, yes. Okay. So definitely not periapical cemental dysplasia, right? Okay, so we have all these changes. We don't have any information from the patient. Okay, now what would you do? It's your patient and you look at it. So what is your working diagnosis? It's a chronic marginal periodontitis, so you start cleaning. Benign generalized self-limiting dysplastic condition, so you keep it and you follow up on it. Hematologic disease, like already having answered, or aggressive malignant marginal periodontitis, so then I refer to a periodontist. Yeah, go down, keep going down. Okay, so I called the doctor, and you know, here talking to a doctor is something, you know, it takes time, because the first you introduce yourself, my name is Dr. Nujaim, I'm a maxillofacial radiologist, and the first answer is what? You're what? They think that I'm selling maybe some painting or some books. I'm selling encyclopedia. No, no, no. I'm a radiologist. X-ray. We look at X-ray. I need to talk to the doctor. And then the first answer is, you know, the doctor is in surgery. All doctors here are surgeons. So after 20, 30 minutes of convincing people, we get to talk to the doctor. And then finally, the doctor called me back. Okay, and we had a discussion. So he said, this is after reading my report. He said, this is the first time he sees a medical report. I told him, doctor, what do you mean medical report? I'm a dentist like you, but I'm a radiologist, you're a periodontist. That's the only difference. But the patient has a big issue. We need to know. He said, well, he did not say anything. The patient did not say anything to me. I told him, okay, please do that. So what did I tell him to do? To do periodontal treatment and reassessment, to do nothing and follow up in 6 to 9 months, referral for medical evaluation, or splitting the teeth and deep scaling and root planning. Remember, for him, the patient is healthy until now. Okay, the patient did not tell him anything. And sometimes you can blame the patients, by the way. Okay, so yes, I'm not gonna see anything else. So yes, I told him, okay, doctor, no, you need to do something. You need to send him for medical evaluation. You need to start by a blood test. There's something wrong happening here. Now, after hours, when he's done, he told me that he called the patient and the patient told him that he has a condition. And the condition is called Erdheim-Chester disease. To tell you the truth, I never heard about that before. So Erdheim-Chester, so I went online and to see I went to see Dr. Google, and Dr. Google told me that this is a rare multi-system disorder of adulthood, okay? Excessive production and accumulation of foamy histiocytes with multiple tissues, within multiple tissues, bone and soft tissue. And then it was described by the WHO as a hematopoietic neoplasm of histiocytic origin. So practically, it's a non-Langerhans disease.
Yeah,
okay?
it's a histiocyte disease.
It's a hematologic disease.
Yeah.
Practically, it's a hematologic disease. Okay. So I don't know if we can call it type of lymphoma or type of leukemia, but probably it's a type of lymphoma, maybe. But so yeah, this is the situation. So no, it wasn't a periapical segmental dysplasia. It wasn't a a periodontal problem. It was way deeper than that. And this is the thing that we need to always, if someone attended my lecture, my last lecture before Corona was in Turkey, in Eskişehir, if you remember,
Yes,
Alper Khan was there. Okay, and I showed you so many cases that patients usually come to the office and the images come to us in one direction and then they go in a completely different direction. And this is one of them. So we have a big responsibility of looking and because we are the eyes of the doctors, we need to teach them, we need to educate them. Yes, we need to tell them, guys, you are wrong, that's not that, even though we're going to be rude a little bit. Anyhow, we live by ourselves, so they don't like us. Okay, so they need to know that we are their eyes, we are there to help them as much as they can help us. Okay, keep going. And case number 4. So again, this is what I get from the doctor, 17-year-old female, and usually they don't tell me that. I found that on the DICOM. Okay, swelling. I swear to God, this is all what they sent me. Where is the swelling? In her foot, in her knee, in her face? We have no clue. Okay, so we know only swelling. Okay. So we have the cone beam, and this we're gonna go to the maxilla now. Okay, I'm going to show you the case. So the lesion is in the left anterior maxilla, okay? And can you see the images? Can you see the
Yes,
cross section?
yes,
Because those are
yes.
the most important, okay? So this is the lesion. The lesion is extending from almost the midline, okay, on the facial aspect to the area of the canine, probably. Okay, and let's look at the content of the lesion, because this is our main index, if you want. This is our main clue. Okay, so what do we see? We see expansion, not very uniform, because you see ins and outs, in and outs, okay? But you see expansion. We see weird development of the cortex. This is not a normal cortex. This is a thickened cortex, probably, or maybe some reactional bone. We see a low density area. Okay, we see a low density area. And on the palatal aspect, we don't see anything. Now, look at how many of these weird trabeculations we have. Okay, you feel that the whole area is like bone marrow, but with a microscope on it. So instead of having the linear bone marrow, you have a thick bone marrow, a linear bone marrow, I mean trabeculation. Instead of thin trabulation, you have thick trabeculation here and there, and that's one, and that's one, and that's one. So you feel like if the bone marrow is on steroid, okay, or he's eating more than I do. Okay, good. So when you see those, and you see that the lesion is localized in one area, and you see that the remaining bone is okay, and the patient is young, and all of this. So what do you think? Do you think it's a benign tumoral lesion? You think it's a malignant tumoral lesion? Can you describe it as cystic, taking in consideration the outline? Is it inflammatory? So related to the APCs, maybe pulp necrosis on what 21, 22, maybe 11, 21, 22, 23, etc. Or it's none of those. Okay, so I see that benign tumoral is, I don't know what none of those could be, but I don't know why I put that. I need to delete it. Okay, anyhow. So yes, the lesion is not cystic, because cystic lesions usually have a round outline, sharp margins, okay, uniform expansion. Usually malignant lesions have less expansion and more perforation. Okay, so you see the lesion perforating the bone, you see bone spicules, you see all these findings. Benign tumoral was my impression when I saw it. Okay, so that's probably a benign tumoral lesion. Okay, type. Now what? When you look at the outline, okay, what is the type of, not the outline, you know, the whole image? What is the typical multilocular development fits in this case? I'm gonna bring it back so you can keep answering, okay, and we can look at it one more time. So you see it's multilocular, we agree on that. So that's a locule, that's a locule, that's a locule. You see the communication between them, or the barriers between them. Okay, so you see it that it has some round effect, more or less. Okay, but in some areas it's more straight. Okay, so it's multilocular, you have multiple septations, and you know, to tell you the truth, all what except soap bubble I don't really like, but even though it has some soap bubble, but when I described it, I put almost all of them, because you have a honeycomb effect, you have the soap bubble. Now the margins at the periphery are scalloping. So you see the scalloping. So you see all the features that we see in benign tumoral, kind of sometimes odontogenic lesion. Doesn't mean that this is odontogenic, but you know, the things that we see very often. You know, if I tell you this is an ameloblastoma, you wouldn't say no. You'd say, yeah, probably. It has some ameloblastoma features. If I say myxoma, maybe myxoma makes some more perforation. You see, so it has all of these features. Remember, the patient is young, etc. So we're dealing with a multilocular, benign, tumoral, okay, and the anterior maxilla in a young patient. The patient is a teenager, okay. So you see, that's the main feature of the lesion. You see the expansion here, okay. Now, what is your primary diagnosis? Okay, remember, taking in consideration the features of the lesion, the age of the patient, and the features. Okay, so giant cell granuloma, desmoplastic fibroma, central fibroma. Think what can happen also in younger patients. Okay, and I'm happy because no one put anything of odontogenic origin, which is good. Which is good. By the way, I don't know who's answering what, so you can put whatever you want, but don't say bad stuff about me. Okay, so. Okay, central giant cell, I'm seeing it big and, you know, fibroma. Yeah, fibroma, remember guys, fibroma is usually more round than that, but it could be a fibroma. It could be a desmoplastic. If it's something, it's going to be a desmoplastic fibroma. Remember, dysplasia cannot grow like this. Dysplasia is more a mimic. I mean, we'll talk about it later. Okay, so put all of those, remember them, each one of you, remember what you put. And if I tell you that the gingiva overlaying the lesion is bluish, like blue, purple, what would you say? And the right answer is getting bigger and bigger and bigger. Yep. Yeah, you see, all the features were fitting what you were mentioning, you know, like fibroma, like central giant cell granuloma, all of those, they were going in the same direction. But one feature shifted the whole thing in a different direction, okay? Or not I'm not gonna say opposite, but it narrowed it, if you want, and it took you to Rome. It took you to the destination, okay? So yes, it was a hemangioma. The case was a hemangioma, central hemangioma, and this is one of the conditions that you or the dentist don't want to play with, because you can very easily cause severe bleeding for the patient, and it's going to be a disaster in your office. Okay, so always pay attention to that. Now, to tell you the truth, if I asked the doctor if he used the stethoscope, if he heard some throbbing, probably he would say yes. And I would put it, but then I will make it, it's going to be very easy for you guys. So we don't want to make it this easy. Okay. But usually whenever you have this, you know, the heat, sometimes with some infrared cameras, you know, they can figure it out, because the area is usually overheated. So just by touching it, you feel that it's overheating. Okay. So this was a hemangioma in a young patient. Okay, we're still okay?
Yes.
Okay, tell me whenever you want to stop. I still have few cases, but we can stop whenever you
No.
want. I know it's
I
getting
think
late.
no one wants to stop. Please go on.
Okay, okay. Yeah, but at some point I'm gonna stop because I'm gonna be done. I'm gonna be, but you know what? I have hundreds of cases,
As
but
you
for
wish.
this presentation, no. Okay, good. So central hemangioma, blood vessel proliferation, tumor. Okay, we're not gonna. You can go and find those. Okay, case number 5. 18-year-old female. This is what they said. Re-evaluate right maxilla. Previous biopsy, BX is biopsy, by the way, showed inflammation only. Okay? You're okay with that? Yeah. Let's see. I'm gonna try to do that, or you know what? I don't want to ruin it. Yeah, I did it. I need to stop doing that.
Where was the biopsy was taken from?
The maxilla, here, this area,
Okay.
this area.
Meanwhile, I would like to make an addition for cherubism. I had a similar case like that. Of course, there's no need for a biopsy, but they made a genetic test. It was a single gene test, and the genetic laboratories didn't have the tests in Turkey. So the family of the patient brought it from United States, I guess, and made the test, and it was positive. And by genetic test, they proved that it was a cherubism in my case. But they didn't make the biopsy, of course.
Yeah, that's good. That's good. At least, you know, because I mean, nothing's gonna happen. You're not gonna kill the patient. You know, it's not a hemangioma and the patient's gonna bleed to death. You see
but
what I
it's
mean?
a kid, yeah.
But still, you know, just by showing a young patient like 12-year-old, showing him the scalpel, and this is gonna be anyhow. So can you see my screen back now?
Yes, boss.
Okay, I promise I will not ruin it anymore. I need to know what happened. Anyhow, so this is the area that we are dealing with. So we have, okay, so we're gonna go through it. Also, younger patient. This is the second molar, the third molar, and this is where the lesion starts. So we see the expansion. Okay. See how big the lesion is. Okay. It's reaching the midline. It's reaching the mid maxilla. Okay, but still non-uniform, but kind of homogeneous with a little bit of osseous changes, but you can still see some trabeculation. So typically not cystic lesion, but you can see all these changes around it. Okay, remember the patient is younger. Okay, and they already biopsy it. Probably this is the biopsy site. Okay, and it came back as inflammation. Okay, type. So what are we dealing with here? So when you describe the cortices, I'm going to show you the cortices back. So do you call this uniform expansion and thinning, uniform expansion with possible interruption, non-uniform expansion and thinning, or uniform buccal and palatal expansion? Let me show you that back so we can take our time. Okay, so what do you call this expansion? Okay, is it uniform? Is it uniform thinning? Do we have interruption beside the biopsy site, of course? Okay, what do you think about the cortices? Do you think those cortices are uniformly thinned like we see in balloon-shaped lesions, or it's more an expansion with irregular outline, especially from the periphery, from the peripheral aspect of the lesion? So it's non-uniform expansion. We have thinning, yes. Maybe some areas of interruption, but I would say it's volume averaging. It's not real interruption. Okay, so this is another view of the lesion where you see the non-uniform expansion. You see it in this area. You see the diffuse outline. You see the trabeculation. You see all these additions to the area. Now, if I'm going to go back to that and ask you about these changes, you know, this type of bone, the type of the bone that is inside the lesion. So how do you call that? Do you call it reactive bone? Do you call it malignant? Those are those malignant features. Is it a benign tumoral or it's a fibroosseous dysplastic? Okay, due to the changes. Oh, here I see the fight. Here I see the fight. And one of them is right, but don't be surprised. Okay, I understand it looks like this plastic, but usually remember this plastic is usually thicker than that. It's denser than that. This is more reactive bone. This is more sclerotic. This is a bone that is reacting to something similar to what we saw in the previous cases. Okay, so you see that the bone is growing, the area is growing, and the bone is resorbing, but then forming again. You see, so because usually sclerotic bone or dysplastic bone is not like this. Okay, dysplastic bone is thicker and it's more compact. Those are, you can call this as failing bone, you know, bone that is developing, but it's not reaching complete maturation, imaging wise. By the way, we're not going to talk in histology. Okay, so this is typical reactive or you know, sclerotic or reactive bone, but still very, very close to fibroosseous. I wouldn't, you know, it's
50-50.
wouldn't go very far. Okay, good. Let's continue. So I'm gonna go and show you the images again. So what do you think about the PDL space and the lamina dura? Are they absent on all the teeth? Are they absent on some teeth and normal on the other ones? Are they normal? Or absent on some teeth and widening of the PDL space on other? Let's look at the images again. Okay. So this is the area of the lesion. Okay, this is the area of no lesion. And you can, I know that cone beam is not the best technique. And I know because of the zoom and all of this, maybe you don't see as clear as I see, but you can see in many areas of normal bone, you can see the PDL space and the lamina dura. Okay, while in the area of our lesion, you don't see any of that. So you feel that the lesion is, you see on one side, you can see it on this one, but you cannot see it on the other one. So you see that the lesion is blending with the PDL space and lamina dura. And whenever the lesion blends with those, so you have the impression of something is happening with the bone. Okay, and there's a in idiopathic osteosclerosis here, but who cares? Okay, so it's normal in general, but on the lesion, wherever the lesion is, we have absence and we have blending of those. Okay, so you see, practically you don't have a PDL space and lamina dura in the area of the lesion. So based on that, the lesion is expanded. The lesion is old because they did a biopsy a long time ago and nothing happened. The lesion has some sclerotic inside, some reactional bone structures inside it. The lesion is blending to the PDL space and lamina dura. This is the in. The outs is, this is not cystic, definitely. This is not malignant, definitely. Okay, so those are the changes. Plus you can add to that, if you want, the history of inflammation. So when they did the biopsy, they found only inflammatory tissue. Remember, in dysplasia, you don't find inflammatory tissue. You find mainly granulomatous tissues in inflammation. You see how I gave you the answer, but you didn't listen to me. You remind me of Hasniya now. I don't know if she's still attending or no.
She's attending.
Yeah, she is. Yeah. Okay, I'm seeing many things. In fact, it was way easier than that. I'm gonna give you the choices. So you think it's a hemangioma, non-specific inflammation, aneurysmal bone cyst, and now everyone got the right answer.
There were too much granulomas in your clues, let's say.
Yeah, you see, so that's why I think this is what induced them in error. I think the inflammatory tissue, the granulomatous tissue, that's why they said it's inflammation. But I really don't know what did they do, but practically they did not touch the case. Okay, so this was in fact a central germ cell granuloma after biopsy, after doing a real biopsy, good biopsy. Okay, now how to treat those cases, it depends. You have many schools, many people, you know, they think about them differently. Some people say, you know, you don't touch it. Some people go in, you know, some curettage, stimulate new bleeding. Some people put some gel foam with steroids with cortisone in them. You know, they have multiple ways to treat that. But after all, you know, we know it's a benign thing, and you know, step by step, things are going to be okay.
She had no any kind of systemic diseases, right?
No.
Considering the differentials of with Brown
Yeah.
and things like that.
Right. No, she did not.
Okay.
Okay. So case number 6. Now this is a kind of sad case, but okay, let's go through it. Now, 9-year-old male, and this is what they said: cyst in the right posterior mandible, number sign 17 area. By the way, just to let you know, 17 is wrong. 17 is 36. The lesion is in is 38. Okay, and this is what they said. They said 17. In fact, they meant 32, which is the area of interest. Okay, so let's go to the lesion. Okay, as you see, young patient. Okay, and this is the lesion. So this is the first molar, this is the second molar, and this is the third molar, and the lesion is developing around the third molar. Okay, we're okay with that. So now let's go up a little bit and look at the lesion. Yeah, so we start from the ramus, things are okay, and then suddenly we have the defect. We have thinning of the buccal of the lateral aspect of the ramus with no expansion. Interruption of the medial aspect of the ramus also with no expansion. And we can see the third molar. Now I can see some expansion in this area, but clear interruption, some expansion in this area, but clear interruption also. And then we keep going to the second molar. Okay, so we have the third molar, growing third molar. The stage of development is the same, so it's not advanced, but we have a big lesion around it and all the stuff. So this is another view just to give you an idea of what we are dealing with. So what do you think the tissue of origin of the lesion is? Seeing the tooth and seeing the structure around it. Is it the pericoronal sac? Is it the surrounding bone? Is it the mandibular canal? or it's the pulp tissue. Pulp tissue, come on, guys. Okay. Okay, I'm gonna show it to you again one more time. We'll go very fast. Okay, look at the mandibular canal. For the people who are saying mandibular canal, let's follow the mandibular canal. You see it? Okay, so look where the mandibular canal is. You can still see it. We can still see it, right? So the mandibular canal is not involved in the lesion. So you cannot say mandibular canal. So take it out. 13%, guys. 11, 0. Nice. Okay, so in fact, yes. When I looked at the case, and to tell you the truth, I missed it. Okay. Yeah, I thought it's the pericoronal sac, even though the lesion was growing a little bit beyond the pericoronal sac, beyond the tooth. But I think I went very fast. Okay, so let's continue. So this is where the lesion is. You don't see the pericoronal sac widening. You see all of this, and then we saw that. So what do we call this pattern of growth? Do we call it multilocular, unilocular, scalloping of, or infiltrative? Let's look at it one more time. Okay, so we don't see any trabeculations inside the lesion. We see this scalloping margin here in one area. We see expansion, but interruption very fast. Okay, and at some point, you see the pericoronal sac. Okay. Okay, let's continue. So the cortices of the ramus are uniformly expanded with uniform thinning, uniform expansion with interruption, non-uniform expansion, severe thinning and interruption, and interruption with no expansion. No, we have expansion, so this one is wrong. Uniform expansion, no, it's not uniform expansion, even though there is interruption. Non-uniform thinning, that's not uniform thinning. There is interruption in multiple areas. Okay, so yes, the lesion is non-uniformly expanded with severe thinning and interruption, wide areas of interruption, I would say, from the buccal, medial, and superior, like internal aspect of the mouth, or anterior aspect of the ramus, if you want to call it. Okay, good. Now, what do you think? Yeah, bring it down, bring it down, bring it down. 13, go down. Okay.
How old was the patient,
Okay.
Professor?
I'm not gonna answer this question
Okay.
because I have following question, and this will guide us toward where we are. So remember the pattern, remember the numbers, and what the hell is that? So what do we call it? I'm expecting 100 right answers now. Yep. Yep. So this was a typical Codman triangle. Okay. So we're not going to waste more time. Periosteal, yeah, it's a periosteal reaction. Yeah, Codman triangle is a periosteal reaction, but it has a typical shape that we see it at the periphery of. Now, if I go back to that, do you think you can change your answers?
Yes.
Yeah.
No.
No, they insist.
Yeah.
Okay. Yeah, to tell you the truth, I missed that, and I thought it's something different. And based on that, what do you think your primary diagnosis is? We don't want to waste a lot of time on it. Okay.
Mhm.
I'm gonna stop at this one because features most consistent with osteosarcoma, predominantly fibrous and myxoid, conventional or high-grade osteosarcoma. I missed that. I did not imagine it's an osteosarcoma. So yeah, that's why I told you it's a sad case. You know, it's a young patient, but I think he's gonna lose part of his jaw now. But it is what it is.
This is a sad one. Yeah.
Yeah, I know. I know. Okay, so that's the last one. This one is very easy. Okay, I know you will always guess that because you saw hundreds of those. But maybe that's the different way to present it, because this is the first time I see this presentation of this condition. Oh my God, it's almost an hour and a half. I need to stop doing that. Okay, so yeah, before we go that. Okay, so that's the panoramic reconstruction. I'm gonna move it so you can see the changes everywhere. Okay, so we can see many of those here. We can see here. We can see this one. Okay, we can see this one in the maxilla, etc. So whenever I have multiple lesions, oh my God, that's what's so fast. Okay, so we're dealing practically with a systemic condition. Okay, because we see the lesion in multiple bones, what we call polyostotic, or it can be only in one bone, but in multiple areas, which what we call multifocal. So it's multifocal or polyostotic. Okay, and they are all seen in systemic conditions. Now, systemic conditions could be a big array of conditions, but they all represent in multiple areas. So whenever I see this, what is the typical name for that? Yay! Okay, so that's not a soap bubble. It's incomplete soap bubble if you want. That's a typical scalloping. It's not the hydraulic effect, because the hydraulic effect usually is more uniform. And mass effect, no, it's not, even though most of cystic lesions, they have the mass effect, but the mass effect, we use it for displacement. So we have displacement of a tooth, we have elevation of the sinus, we have inferior displacement of the mandibular canal. This is what we call the mass effect. And mass effect can be seen in cystic, benign tumorals, but it's less in malignant lesions and inflammatory conditions. So yes, this is a typical scalloping. Now, look how many of those we have. So I gave you the answer. What do we call that? Multilocular, multifocal monostotic, polyostotic, because we see it in the maxilla and mandible, and multicystic. I don't know what multicystic is, but I had to put D, so I had to come up with something. Okay, so this is a typical polyostotic. So what is the syndrome? Who? Who's that? So what do you think the syndrome is? This was the easiest one by far. Seriously?
Maybe it starts with G
Okay.
or something we can say.
Okay. Yeah.
All right. It was a joke
Now
for
it
you,
started.
Professor. It was a...
Okay. Just to let you know that, yes, this is the Gorlin-Goltz syndrome. Now, this case was already treated, and they took multiple cysts out in China. Okay. But the patient came to the US, and after a few years, they took this and they found that. So this is, in fact, a recurrent Gorlin-Goltz or recurrent odontogenic keratocyst in a Gorlin-Goltz syndrome. Now, remember, guys, and that's something that I learned from the cases that I saw. Whenever you see small locules, small lesions like this, think about recurrence. Recurrent ameloblastomas, they don't present with the typical soap bubble that you see. No, you see small locules. OKCs, when they recur as small locules, multiple small locules, more than big ones. Maybe because of the reactive bone around it, maybe we don't know. So this area is definitely treated, because if you look at it, you see that this is not a normal bone. So they had some surgery done here, and this area probably they did not treat it. So this is a primary area, probably. But if you look at some areas, you think that, yeah, probably they did. You see here? So they probably did something here, but maybe not here. Okay, so you can see the difference between areas of already treated lesions, areas of probably not. This is definitely not treated, and this area where, probably they had the lesion before, this area. Okay, so yes, it was a Gorlin-Goltz syndrome. Remember that this can be seen in so many presentations. You can have the fork cerebri, you can have the hypertelorism, you can have the bossing, you can have all, the palmoplantar, keratodermy, palmoplantar, you can count them. Okay, so I'm gonna say thank you. It was a long session. An hour and a half. I'm so sorry it took us more than that. Hopefully you enjoyed it.
Yeah, Professor, it's never enough when it's your lecture and when you, as these precious case reports.
Thank you.
I want to thank you on behalf of the Turkish Oral Diagnosis and Maxillofacial Radiology Society for your beautiful presentation, and please accept our gratitude. And as an addition, I have a funny idea. Sometimes there are some descriptions in interpretation that we use, like fisherman's net or some other stuff. Are there any conferences or any panels that are only discussing these descriptions? Because as we proceed, there are some new descriptions maybe for the young generations. What's your idea about it?
Yes. Okay. Let's agree on something, Alper. Those descriptions, the honeycomb, fisherman net, or the damaged fisherman net, or soap bubble, or ground glass. Those are mainly based on conventional images. Remember, the people who came up with those, they were based on conventional images. Now, in advanced imaging, you can still apply them. But to tell you the truth, personally, I don't like them. Okay, I prefer not to. I prefer to say round multilocular to describe the soap bubble, okay? Straight irregular to describe the what's their names, the fisherman net, okay? Straight geometric features to describe the honeycomb or the cases that we see. So I prefer to use that. Now, to tell you the truth, we need to look in the new books and see what those big people are saying. You know, like Lisa. I don't know if Lisa Koenig is using any of those terms anymore. I don't know if I don't know who the people who are continuing the saga of White and Pharaoh. I think now it's Sanjay.
Tamimi
Sanjay
as well,
Malia and
I
Ernie
guess.
Lam. I think they are continuing the series. I don't know if they are still using those. So to tell you the truth, no, there's no one place you can find them. You want to look in some old books, maybe you can find them and they can describe them. But I prefer personally, I prefer not to. One. Second, something personal I prefer not to is not use names. Okay, like for example, the lingula on the lingual aspect, you know, the mandibular foramen. Okay, so we used to call the spine of Spix is the person who discovered it. You see, so I prefer not to use that. But you know, some of them you have to. Gorlingoltz is Gorlingoltz. You know, Gardner is Gardner. Don't waste your time. Okay, but they all have more scientific names. But no, to tell you the truth, I don't know any place where you can go and find these fisherman net, you know, names that you're looking for.
Thank you, Professor. So I'm looking at the, is there any questions to our professor regarding the cases or any questions? We wait for the audience. Okay. Cansu says, thank you, doctor. That was an excellent presentation for us to refresh our minds in these challenging times. And she also mentioned it's always great and inspiring to listen to you. The last recurrence image especially was rare and instructive, she said. And Dr. Müjgan said, thank you for your presentation.
Thank you.
Okay.
Thank you, guys. And hopefully we meet soon in a better condition, better situation, happier situation. Okay.
Hopefully.
And Turkey is always my favorite place. So whenever I get the chance, hopefully I'm going to go and visit. Okay.
You're always welcome, Professor.
And the food is good also.
Okay. So it's time to end the webinar, I guess.
Okay. Yes.
Okay. Hope to see you soon, Professor.
Thank you. Take care. Say hi to the family, please. Okay.
Thank you. Okay.
Thanks. Bye.
Değerli katılımcılar, webinarımız burada son bulmakta. Bir dahaki webinarımızda görüşmek üzere. Hoşça kalın.